Hi everyone, I'm Kristen Dalton, a licensed and certified genetic counselor with the Reproductive and Genetic Health team at Illumina. I'm joined by Dr. Chavez, Chief of Maternal Fetal Medicine at Winthrop University Hospital, and Dr. Garg, OBGYN at Scripps Health. Thank you, Dr. Chavez and Dr. Garg, for being here today to review tips on how to discuss non-invasive prenatal testing with patients. Today, we are going to discuss screening and diagnostic testing for fetal aneuploidy during pregnancy, with a focus on the screening option of non-invasive prenatal testing, otherwise known as NIPT, or cell-free DNA screening. We are using the ACOG and SMFM 2016 practice bulletins as the guidelines for our conversation. These are excellent resources for further information and should be reviewed by healthcare providers who discuss aneuploidy screening and diagnostic testing options with patients. We should start with some background. It is important for patients and providers to understand the key differences between a screening test and a diagnostic test. Screening tests assess if a patient is at increased risk of having a pregnancy affected with a particular condition. Diagnostic tests, on the other hand, determine with as much certainty as possible whether or not a specific condition is present. It is important that testing is an informed patient choice that fits with a patient's individual clinical circumstances and her values, interests, and reproductive goals. Dr. Garg, can you comment on why providers should talk with their patients about screening and diagnostic testing for aneuploidy?
Sure, Kristen. Aneuploidy, which is the presence of one or more extra or missing chromosomes, is relatively common and can have a significant impact on reproductive outcomes. We know that approximately 1 in 150 live-born children are affected with a chromosomal abnormality. Down syndrome is the most common aneuploidy seen in live births and affects approximately 1 in 800 newborns. The presence of a chromosomal abnormality can have a significant impact on a child's health and development. Approximately 5 to 7% of all infant and childhood deaths are due to chromosomal abnormalities. There's an even higher prevalence of aneuploidy during pregnancy, since pregnancies with aneuploidy may not survive or continue to delivery. Chromosomal abnormalities are present in about half of recognized first trimester miscarriages and in about 5% of stillbirths. While we know that the chance of having a pregnancy or child affected with aneuploidy increases with increasing maternal age, the fact is a woman of any age and of any race or ethnicity can have a pregnancy or a child with a chromosomal condition.
Dr. Chavez, anything you'd like to add?
Yes, Kristen. The overall reason why we offer testing for aneuploidy is because it can allow for the patient and her family, as well as the healthcare providing team, to be aware of an increased risk of or diagnosis of a chromosomal abnormality during pregnancy. This knowledge can allow for better preparation and more personalized medical decision making when we know that there's a high risk or a diagnosis of a chromosomal abnormality. This allows us to educate the patient and her family about the condition and to counsel them regarding options such as having further evaluations and consultations during the pregnancy, referral to a tertiary care center if appropriate, establishing a delivery plan, non-continuing the pregnancy, or making an adoption plan.
There are many screening and diagnostic testing options available now, and we can realize it's difficult to review so many options with patients, so many testing and screening options with their own complexities and nuances. Dr. Garg, what do you usually review with patients when you are introducing them to this topic of aneuploidy and testing?
First, it is important to discuss with a patient her specific risk for fetal aneuploidy. The risk estimate I provide to a patient is specific to her based on all of the information I have available to me. This could include her age at delivery, her gestational age, if she has a history of a previous pregnancy or child with a chromosomal abnormality, if she or her partner have a chromosomal rearrangement such as a translocation, and whether or not there are fetal abnormalities detected by ultrasound. All of these factors influence her chance of having a child with a chromosomal abnormality. I let a patient know that there are risks, benefits, and limitations to all of the available screening and diagnostic testing options. It can also be helpful to refer patients to a genetic counselor or MFM to review the testing options in more detail, especially if patients have more questions than our time allows to address fully during a regular OBGYN appointment.
Absolutely. Clinical genetic counselors and MFMs can usually spend more time with patients to review the various testing options, benefits, risk, and limitations in the context of the patient's desire for information. and how she might use that information during the pregnancy. What risks or conditions does she want to know about during the pregnancy? How definitive does she want our result to be? How would she use this information? How would it affect her pregnancy-related decision-making and management? There are many factors that play a role in a patient's decision-making, including her values, culture, reproductive goals, the cost of the testing, her gestational age and parity, and possibly her past obstetrical history and family history. The goal should be to help the patient make an informed decision that is in line with her individual values. And we need to remember that the patient has the right to elect or decline these testing options.
There certainly are many options available for aneuploidy screening and diagnostic testing, and the list of these options has changed and expanded over time.
Yes, right now screening test options include first trimester combined screen, quad screen, integrated screen, stepwise sequential screen, contingency screen, ultrasound, including the nuchal translucency assessment, and the most recent option of NIPT. Diagnostic testing includes karyotype analysis and chromosomal microarray. Cells can be obtained for these diagnostic tests via chloride villi sampling or amniocentesis. Both procedures are available at specific times during the pregnancy, with a CVS usually being performed between 10 to 13 weeks gestation, and most amnios for aneuploidy testing are performed between 15 to 20 weeks gestation, although amnio can also be performed at a later gestational age. Both procedures are associated with a risk of pregnancy loss. According to the most recent ACOG practice bulletin, the procedure-related loss for CVS and amniocentesis is approximately 0.1% to 0.3% when performed by experienced healthcare providers.
Dr. Chavez, you just mentioned that NIPT, or cell-free DNA screening, is the most recent option for fetal aneuploidy screening. Before we discuss how to provide pretest counseling specifically for NIPT, Dr. Garg, can you provide a brief summary of what cell-free DNA is?
Yes. Cell-free DNA refers to the small fragments of DNA that are released into the bloodstream through the natural process of cell death or apoptosis. When a woman is pregnant, her blood contains her own cell-free DNA as well as cell-free DNA from her pregnancy. The fetal cell-free DNA is mostly derived from the placental cells, specifically the cytotrophoblastic cells, rather than directly from fetal tissue. Most of the cell-free DNA in maternal blood is of maternal origin. About 2 to 20% of the total cell-free DNA in maternal blood is coming from the pregnancy. The term fetal fraction refers to the amount of cell-free DNA in maternal blood that is of fetal or actually placental origin. Non-invasive prenatal testing involves screening for fetal aneuploidy by analyzing the cell-free DNA fragments in a maternal blood sample.
Thank you. So what are some of the benefits of NIPT that you review with patients, Dr. Garg?
I like to let the patients know that NIPT provides screening for the most common aneuploidies, which is trisomies 21, 18, and 13, as well as the sex chromosome aneuploidies. The sensitivity and specificity are very high and vary by condition. ACOG and SMFM cite sensitivities ranging from 91% for the sex chromosome aneuploidies to 99.3% for trisomy 21. The specificities of NIPT for these conditions are 99.6% or greater. NIPT is the screening test with the highest reported detection rate for trisomy 21. And one of the major benefits of NIPT is the low false positive rate of less than 1%. This is significantly lower than the 5% false positive rate quoted with the most traditional serum screening tests. The chance of a false alarm is lower for patients who choose NIPT compared to those who have a traditional screen for aneuploidy, and in my practice, this leads to fewer patients being worried and undergoing an invasive procedure when their pregnancy truly is unaffected. Also, the accuracy of sex determination is generally greater than 98% with NIPT. NIPT is available early in pregnancy from 10 weeks gestation and throughout the rest of the pregnancy, which is an advantage over other testing options. We all know sometimes patients come late to prenatal care, and traditional screening is only available through 22 weeks. So for later gestational age patients, NIPT is still a screening option. It is a blood test which makes it relatively easy to incorporate into routine clinical care, as most of our patients are already comfortable and accustomed with getting their blood drawn. The turnaround time is relatively quick, but depends on the particular laboratory or test, So it is important for us as ordering physicians to familiarize ourselves with the lab that is doing the testing. And because NIPT is not associated with a risk of miscarriage, NIPT can be a reasonable choice for many patients who are declining diagnostic testing or are unsure about diagnostic testing and desire a more refined risk assessment before making a decision about diagnostic testing.
Thank you. We mentioned before that all tests have limitations. What do you review with patients regarding the limitations of NIPT, Dr. Garg?
Well, although the chance of receiving a false positive or false negative result is low, patients should be made aware that it is still possible to receive a false positive or false negative result. This is the nature of any screening test. It is also possible that a patient can have her blood drawn for NIPT, and I might need to tell her later that there is no result due to a failure with the test processing. The risk of NIPT failure varies and can be as high as 8% depending on the lab and methodology being used. Again, as a provider, you should be aware of your specific lab's failure rate. I tell the patient that if the NIPT fails to give a result, this may represent an increased risk for aneuploidy, and this would require additional follow-up. We also need to remind patients that NIPT doesn't test for everything. Patients often think that NIPT and even other screening and diagnostic tests can tell you everything about the health and the development of their child. Patients should understand that NIPT does not screen for autism, all causes of intellectual disability or learning disabilities, all causes of birth defects, mental illnesses such as depression and schizophrenia, and genetic conditions like muscular dystrophy or cystic fibrosis. It does not detect all chromosomal abnormalities and doesn't screen for teratogenic exposures like fetal alcohol syndrome or effects from perinatal infections or maternal diabetes. For that matter, routine aneuploidy testing by CVS and amnio will also not diagnose everything.
So it's still important to obtain an accurate and complete medical, reproductive, and family history, and review carrier risks and carrier screening results, and assess for teratogenic exposures, and take ultrasound findings into consideration, correct?
Yes, all of this is still important. I may find something else in the history that leads me to discuss diagnostic testing by CVS or amnio as a better option. For example, if the couple has a previous child with cystic fibrosis, I would discuss prenatal testing for cystic fibrosis and aneuploidy diagnostic testing on fetal cells obtained by CVS or amnio.
Let's remember that these limitations are not unique to NIPT. Even diagnostic testing is not 100% sensitive or specific, and although it is rare, it is possible to have a test failure or no results even after performing or attempting to perform a CVS or an amniocentesis. I also have to clarify with patients that other screening tests and diagnostic tests do not provide information about all possible conditions. Diagnostic testing often refers to the testing for chromosomal abnormalities via a karyotype or microarray, but this does not diagnose all single gene disorders or birth defects. Regarding the example Dr. Garg had just mentioned, cystic fibrosis is not routinely diagnosed on amnio or CVS unless you specifically order based on appropriate clinical indication.
Good point. So what other topics do you consider when discussing NIPT with patients, Dr. Garg?
We need to remember in the May 2016 practice bulletin, ACOG and SMFM recommended that we do not follow the old paradigm of using maternal age alone to determine when aneuploidy screening or diagnostic testing is offered to a patient. It is now recommended that aneuploidy testing options, including NIPT, are discussed and offered to all women early in pregnancy, ideally at their first visit. It is helpful to provide the patient with accurate, up-to-date resources, including printed information. We should also keep in mind that there may be a financial cost to the patient depending on the patient's health insurance coverage. So we also discuss the cost and the potential out-of-pocket payment when providing NIPT pretest counseling in our office. Even though the recent ACOG practice bulletin includes NIPT as an option for all women, regardless of maternal age or other risk factors, this is not yet reflected in some health insurance plans. So we may have to assist our patients by providing letters of medical necessity citing the ACOG practice bulletin as appropriate.
So if you had to summarize 5 key points to discuss with patients who are considering NIPT, what would these be, Dr. Garg?
First off, NIPT is a screening test and not a diagnostic test. A positive or abnormal NIPT result indicates an increased chance that a pregnancy is affected, but it is not saying that the condition is definitely present. Second, NIPT provides screening for the most common aneuploidies with a lower risk of false positive or false negative results compared to other screening tests. Third, diagnostic testing and referral to a specialist is recommended if the NIPT result is positive. Fourth, it is possible to have an NIPT failure, which would also require follow-up. And fifth, NIPT does not test for all possible health problems, including intellectual disabilities, autism, birth defects, or other genetic conditions.
Great, thank you. That's a lot of information, but appropriate pretest counseling can be beneficial later when you are disclosing the NIPT result and providing post-test counseling. When you have a patient who receives a negative or normal NIPT result, what do you tell her, Dr. Garg?
I tell the patient that her risk of the condition screened for by the NIPT is greatly reduced. I review with her what the NIPT screened for, and I review the limitations of the test, reminding her that this result does not completely rule out the condition screened for by the test and does not provide any assessment about other conditions. NIPT is not a substitute for diagnostic testing. I also remind the patient that the sex chromosome results are not 100% accurate and that we will still assess the fetal genitalia by ultrasound.
Dr. Chavez, what are the next steps to discuss with the patient if she receives a negative NIPT result?
It is important to use the NIPT result in conjunction with other clinical findings, history, and test results. Patients should know that a detailed ultrasound evaluation is still indicated, and if a structural anomaly is present, diagnostic testing should be offered. Open neural tube defect screening is still recommended as NIPT does not screen for these defects. However, additional aneuploidy screening tests like a combined first trimester screen or a quad screen should not be performed to further assess for fetal aneuploidy.
Patients who receive a positive or abnormal NIPT result are often referred to an MFM and/or genetic counselor. Dr. Chavez, as an MFM, what do you think patients should be told if they receive a positive NIPT result?
Patients should understand the interpretation of what it means to have a positive NIPT result. First, the patient should know specifically which condition her pregnancy is at increased risk for, and she should be provided with accurate and up-to-date information regarding that condition. The patient should understand that the result is associated with a significantly increased chance that her pregnancy is affected with that condition, but the result does not mean the pregnancy is definitely affected. Positive predictive value, or PPV, can be helpful to consider when communicating the interpretation of a positive NIPT result to a patient. PPV takes into consideration the prevalence of a condition in a certain population and helps to answer the question, given the positive NIPT result, what is the chance that this patient's baby is affected with a specific chromosomal condition? The Perinatal Quality Foundation NIPT predictive value calculator can be used to help providers calculate a PPV. This online tool provides providers an option to select a chromosomal condition and the maternal age at delivery to establish a prevalence, or providers can input specific prevalence, say based on a quad screen or first trimester combined screen result. You can also adjust the sensitivity and specificity to match your specific test performance metrics. This information will also be used to calculate the PPV. Of note, this calculator can also be used to calculate a negative predictive value for negative NIPT test results. It is important that the patient is aware that the positive NIPT results may represent a false positive. Therefore, diagnostic testing via CVS or amniocentesis is recommended after a positive NIPT result, particularly before an irreversible action such as a termination is taken. ACOG and SMFM state that this recommendation is be clearly stated. A referral to a genetic counselor and or a maternal fetal medicine specialist should be offered for further discussion and evaluation. And another next step is to consider a comprehensive ultrasound evaluation, as this may provide helpful clinical information. Ultimately, the NIPT results should not be considered in isolation. It is still important to consider all relevant clinical findings and risk factors, such as ultrasound findings, maternal age, pregnancy and family history, and the results of any previous aneuploidy screening test. However, it is not appropriate or cost-effective, for that matter, to follow up by ordering a traditional aneuploidy screening test or repeating the NIPT with the same or different technology.
For those patients who have a failure with NIPT, what do you tell those patients, Dr. Chavez?
Excellent question. The patient has the option to have her blood redrawn and sent to the laboratory again for NIPT if the first sample fails to yield a result. However, this obviously further delays the process, and there is still a chance, as much as 40 to 50% according to ACOG practice bulletin, that the second sample could also fail to give results. This could be an important factor to consider, especially depending on the gestational age, when counseling a patient about the option of a redraw. It is also important for the patient to know that there are some publications showing evidence of an increased risk of aneuploidy when NIPT sample fails to give a result, as much as 22% risk in one publication. Therefore, it is appropriate to refer the patient to a genetic counselor and or a maternal fetal medicine specialist for further discussion and evaluation, and also offer a comprehensive ultrasound evaluation and diagnostic testing via CVS or an amniocentesis. Unfortunately, high failure rates can lead to more evaluation and diagnostic testing in truly unaffected pregnancies. As Dr. Gar mentioned previously, the failure rate varies depending on the lab and methodology, so providers should be aware of their specific lab's failure rate.
Thank you. So can you provide post-test counseling for us with 5 key take-home points, Dr. Chavez?
Sure, Kristen. First, NIPT is a screening test and is not a substitute for a diagnostic testing. As with all screening tests, there is a chance of a false positive or false negative results with NIPT. Although the chance of a false positive or false negative with NIPT is less than with our experience with traditional aneuploidy serum screening. Second, because NIPT does provide high sensitivity and specificity for most of the common aneuploidies, additional screening tests for aneuploidy should not be performed after a patient has NIPT, as this approach is not cost-effective and increases the risk of receiving a false positive result. Third, it is important to consider NIPT results in the context of a patient's medical history, other clinical findings, test results, whether NIPT result is positive, negative, or fail to provide a result. Management decisions should not be based on the NIPT results alone. Fourth, and related to the previous point, considering that positive predictive value and negative predictive value can be helpful when providing an interpretation of NIPT results for a specific patient, use of an online PPV or NPV calculator can help with this tremendously. And last, it is important to offer diagnostic testing referral to a maternal fetal medicine specialist and or genetic counselor if the NIPT result is positive, or if the NIPT fails to provide a result, or if the NIPT result is negative but fetal anomalies are detected on an ultrasound.
Thank you. We've covered a great deal of information already, although there is certainly more information regarding NIPT that can be discussed with patients and OB care providers. What resources do you recommend for further information?
The most up-to-date ACOG and SMFM practice bulletins are essential resources for the healthcare provider. ACOG also has additional resources for providers and patients listed on their website.
The NIPT predictive value calculator site also has helpful definitions and additional resources as well. Another potential resource will be the Perinatal Quality Foundation's Genetic Education Module, or GEM as it is referred to, for providers and patients.
And the National Society of Genetic Counselors has also developed helpful handouts for providers and patients. These handouts are available on the NSGC website. I want to thank both of you, Dr. Garg and Dr. Chavez, for taking the time today to review how you discuss NIPT with your patients. Thank you.